Thank you for joining us. We're glad to have you here. So this is our second webinar of the new year. It's on ophthalmologic emergencies with Dr. Bethelehem Mekonnen. So before proceeding with the webinar, I would like to say a few things about Yetenaweg. Yetenaweg is registered in Pennsylvania, USA as a nonprofit organization and is run entirely by volunteer members. So it has more than 150 active volunteer members across 5 different countries and counting more. So it initially started, it had a humble beginning with only 2 original members or forming members that has now grown to accommodate more than 150 active volunteer members over 5 different countries spanning different continents. So its projects and engagements can be seen in 4 aspects. So the first is health promotion, which is usually done via discussion in articles through usually regarding the general public health and health policy and implementation as well. The other is via community engagement. This could be through inclusivity trainings or equity projects. It could be fundraising campaigns or blood donation or blood drive campaigns. The other is mentorship and skill sharing. There will be direct mentorship. It could be regarding whether their career or professional development through webinars or on one-on-one mentorship and skill sharing. And the last is through medical education, which is usually done via research and QI projects, and through continuous medical education, many such as this one. So as you can see from the image, there are several of our members in several events that we had. It could be through blood donation campaign, as you can see from the image. The other is sign language inclusivity training, and the other is through donation to several various non-governmental organizations. And we also had another event, the Health and Art event that was held months back, as you can see from the image. This is also more image showing what we do. And as you can see on the left bottom corner, there was a voluntary service also provided at the Art and Cell exhibition. There was screening procedures that were done for the attendees. So Yetenaweg and Roha also collaborated in a health article writing competition, also in collaboration with IMSA. So the third round of article writing has commenced and is well underway. It's usually done in collaboration with IMSA. Roha Medical Campus will usually award travel grants to 2 health article competition winners, whereas Yetenaweg will award pulse oximeters for the top 20 winners, Littmann stethoscope for the top 3 winners respectively. And the top 5 winners will also get internship opportunities at Roha Health and other partner institutions. So as you can see from this slide, on the left is the 2021 article writing competition winner receiving her award from our health minister. And here on the right are the awards that were prepared for the 2022 winner. It was announced online, and unfortunately we do not have the image. And the third article writing competition is well underway. So one of our other engagement is in collaboration with Roha Research Fellowship. So Roha Research Fellowship in collaboration with Yetenaweg has prepared a research Q&A project with several aims and missions. The first is to increase the versatility of the healthcare professionals in terms of applying scientific research to the healthcare practice, to establish a network of ETPR researchers and to create a lasting learning and information exchange platform, and to foster recognition in commercial and business world, and to encourage key stakeholders and business entities to invest in the scientific research. So the first was in collaboration with Addis Ababa University Medical Faculty or the Kurambasa Hospital. So it started on March 14th. It mainly included 3 departments, being oncology, radiology, and internal medicine. Research grants were awarded for 3 winners. Mentorship were also awarded for 10 winners. The other was done in collaboration with St. Paul Hospital, Millennium Medical College. It was provided for medical students, mainly interns, because they usually undergo research as a partial fulfillment for the degree of Doctor of Medicine. So research grant is going to be awarded for 2 winners. It has already launched and is well underway. So these are the research and QI fellowship winners from the Kurambasa Hospital. As you can see from the image, there are 2 winners from internal medicine, another winner from radiology, and another recipient of the award is from oncology. So besides the monetary awards that they are provided with, they are also provided with several opportunities to learn and further advance their careers in their future ventures. So when we come to the CME, as you all know, stands for Continuing Medical Education. So Yetenaweg partners with Ethiopian Medical Association, the Ethiopian Society of Cardiac Professionals, the Ethiopian Dermatology and Venology Society to provide continued training for healthcare professionals. I'm sure many of you have attended our webinars we've had so far. There have been more than 30 webinars so far. The average webinar attendee is usually from 150 to 200 healthcare professionals. And I can already see we have 113 participants and counting. So in 2023 alone, we've planned to host 40 webinars focusing on non-communicable diseases, on current issues, on mental health, and on sexual and reproductive health rights. So we invite renowned international speakers that are experts in their respective fields. So you can access our previous CME sessions on our official YouTube. So you can check Yetenaweg's YouTube channel. Link will be provided in the chat shortly. So you can also get updates about our upcoming CMEs by joining Yetenaweg's Telegram channel that is made specifically for healthcare professionals, and also by following our social media posts on Twitter, Facebook, LinkedIn, and Instagram. We will post the respective links in the chat. So in order to get the best experience from the webinar, once the webinar is done, you can send your questions to the Q&A or directly to the chat box. And by the end of the webinar, you might also have a chance to ask the speaker directly if you raise your hand. So to get the CU certificates, as an attendee, you must fulfill the following criteria. The first is you must be able to attend the whole session virtually, because the minutes will be checked by the Zoom attendees. You must be able to fill the Google form for personal details in attendance, and you must be able to score 50% or more on the post-webinar quiz. And if you are able to score 50% or more, you will get your results right away, and you'll also be provided with 2 CU points and a certificate. The certificate will usually take 1 to 2 weeks to be delivered on your email, so we ask you to wait patiently. So having said this, today's guest speaker is Dr. Bethelehem Mekonnen. So I would like to say a few things about our presenter. Dr. Bethelehem Mekonnen is a clinical assistant of Professor of Ophthalmology at Bayer's Eye Institute, Stanford University, specializing in cornea and external eye disease. She obtained her Bachelor's of Science from Meredith College in Raleigh, North Carolina, and attended medical school at Yale University School of Medicine. Following an internship in general surgery at the University of California, San Francisco, she completed her ophthalmology residency at the University of California. And she subsequently received cornea, external eye disease, and refractive surgery training at Bayer's Eye Institute, Stanford University. She has a strong interest in working to improve eye care delivery in sub-Saharan Africa through partnership in clinical work and residency education. She also enjoys teaching and mentoring medical students, residents, and fellows. So with that said, I would like to welcome our guest speaker today, Dr. Bethelehem Mekonnen.
Right. Hello, everyone. Thank you so much for that introduction. And I would like to really thank the organizers of the CME Yetenaweg organizers for inviting me, as well as for just putting all the work to put these really excellent CME sessions together. So I want to just congratulate all of you for this wonderful program. Today, I'm going to be talking to you about ophthalmic emergencies. And this talk is really directed to the non-ophthalmologist. It's intended to address some very common ophthalmic emergencies that you may be dealing with, and really an approach to those patients. It's not an exhaustive talk of all possible things you might come across, and each topic really deserves an hour on its own. But this is really just to remind the attendees of some important considerations in these patients that could really save vision. So with that, I will start. All right, so looking at the learning objectives today, my plan would be to briefly review the eye and orbit anatomy, talk about the eye exam for the non-ophthalmologist, as well as talk about some common acute eye complaints and how to approach them. We'll also address assessment and management of ocular and orbital trauma patients. So In case it's been a while, I'll review some of the orbit anatomy that's relevant to the urgent evaluation of ocular emergencies. So as you might recall, here's an image of the orbit with the a sagittal view of the orbit with the lateral wall of the orbit removed, so you can visualize the whole orbit, and you see the globe there surrounded by the extraocular muscles of the eye. And all these muscles coalesce into the orbital apex through which the optic nerve leaves the orbit in that orbital apex area. The whole orbit is cushioned by a fat pad, as well as suspended by a fibrous connective tissue. So although you see there that anteriorly the eye is open, this is really a confined space. And this is very relevant because any expanding lesion, such as a hematoma in the retrobulbar or behind the globe area, can really increase the pressure in the orbit to the point where it might surpass the MAP, the mean arterial pressure, and essentially prevent blood supply to the eye, to the optic nerve, to the retina. So we'll talk a little bit further about that, but the anatomy is important to appreciate here. In the image on the right, I am showing you there the lateral orbital rim is right here, and you're seeing that fibrous connective tissue, the lateral canthal tendon anteriorly that's holding the eye in place. So when you have that kind of an expansile mass in the orbit, that cut that we make at the lateral canthus for lateral canthalysis is really right here to expand the orbit and allow the pressure to be reduced in the orbit. So this is just a good reminder that orbital compartment syndrome can happen when that pressure is elevated in the orbit. And then I want to also just remind everybody of the ocular anatomy that's relevant here and in the assessment of vision loss in the acute setting. So you can divide the eye into the anterior segment and the posterior segment. So the anterior segment of the eye is what you can see and assess very readily. So here's the sclera. You have the clear cornea here through which you see the anterior chamber and the iris. And then behind the iris is where the lens sits. So in the sagittal view here, you're seeing the cornea, the anterior chamber, the iris. Here's the ciliary body. Here's the lens. And so here at the equator of the eye, which we consider, kind of dividing the eye into the anterior and the posterior segment, and you have the rest of the eyeball, which is the posterior segment involving of the retina and the optic nerve. So you can just think of the anterior segment being involved with the transmission of light to the posterior segment, which its sole purpose is to perceive light and to transmit that information to the brain through the optic nerve. And then, so that's the just relevant eye anatomy. And then moving to the aqueous relevant anatomy, we'll obviously talk about acute angle closure glaucoma in a little bit, but I also want to just remind you of how fluid moves inside the eye. And this is how the eye, if you think of it as a water balloon, that's how it stays inflated, is because there is constant aqueous produced in the eye. So the aqueous production happens here in the ciliary body, which is behind the iris. So here in this image, you're seeing a piece of the iris missing, so you can visualize the ciliary body behind the iris and sort of adjacent to where the lens sits. And that fluid that's produced then moves anteriorly through the pupil into the anterior chamber and drains through the trabecular meshwork, which is the angle produced by the cornea and the iris there. So fluid drains through that space. In the acute angle closure patient, this angle is closed. So fluid is being produced constantly, but it's not able to drain out. Then that raises the pressure very, very high. So we'll talk about that in a little bit. So In terms of classification of ophthalmic emergencies, for our purposes today, we'll divide them into the trauma issues that you might deal with, infection, inflammatory issues you might deal with, and the ocular pathology, or things having to do with just the anatomy of the eye, or vascular issues, just for our approach. So it's important to think about, similar to the anatomy, it's important to think about why the patient has lost vision. So is this a problem with the transmission of light, or is this a problem with the perception or transmission of light? So if you approach it in that way, it becomes a little bit more manageable. So if we're thinking about blocking of transmission of light, we're thinking about the anterior chamber and things that may be interfering with light passing through the eye. So chemical burns, corneal ulcers, endophthalmitis, a hyphema, or a blood in the anterior chamber, all will interfere with light transmitting through the eye, versus things that could prevent perception, right? If a patient has a retinal detachment, if they have an optic neuropathy from angle closure glaucoma, or if they have a vascular event that has now damaged the retina, all these things will interfere with the perception of light. So important to think of it in that way, as a way to approach the patient with vision loss. So in the initial evaluation, you have a patient in the acute setting who's presenting typically with vision loss and pain. So it could be both or one of those things. And those are, the most common acute complaints that you're going to have. So the patient has lost vision. It's really important to understand the extent of vision loss in your sort of making your differential diagnosis. So were they able to read yesterday and now all of a sudden, aren't able to see at all, or is it a reduction in the vision of a certain extent? So the extent of vision loss is important. Whether or not it's associated with pain is very important. So as we'll go through some common issues, typically you can divide them as a painful vision loss or a painless vision loss, and your differential diagnosis could vary based on that. And then getting any associated issues along with the vision loss is very helpful. So in a patient with a retinal detachment, they would typically have a lot of floaters and flashes of light that they see prior to vision loss, very helpful in your differential diagnosis. Or a patient with a vascular event such as a central or branch retinal vein occlusion could have had some episodes of vision loss prior to that resolved, and then now they have a permanent vision loss that did not resolve. So all understanding what has been happening, as well as any associated remarkable things, remarkable aspects of the history, are important to elicit. In the trauma patient, you have to really understand the mechanism of injury. The mechanism will really help you try understand what you need to do to assess this patient. So a patient who's been doing work with metal on metal and could have a flying foreign body that may have injured the eye is a very important part of the history to get. In the Western world, contact lens wear is very, very common. It's a very, very common cause of infectious causes of the eye. So we definitely get that history. And it's important to know if a patient has any device in the eye, such as a contact lens. And then, of course, it's always important to get the full surgical history of the patient. If they've had recent eye surgery or periocular surgery, you can most certainly blame anything on that in the peri-surgical time period. So very important to have that history, of course. And then the patient's medical history and medication history is very important. As you may know, there are anticholinergics that patient may have taken that could induce an acute angle closure attack. So getting that history is very important. Moving on to the eye exam. As a non-ophthalmologist, you might be limited in the extent of assessment you can do based on what you have available to you at the time you're evaluating the patient, or this could be a family member you're evaluating. So, but you have to try to do as much of the exam as you can so that you have as much information to go off of to making your differential diagnosis. So we always start any eye exam with a vision assessment. So vision check, followed by a pupillary exam, an eye pressure exam, an eye movement exam, a confrontational visual field, which is a gross assessment of the patient's field of vision. And then if you have a slit lamp available, such as one I'm showing here, that's wonderful. But if you don't have a slit lamp, you can do quite a bit with a pen light exam, up close with the patient. And then, of course, if you're not able to really assess adequately with a direct ophthalmoscope, a dilated eye exam is very, very helpful if you have the ability to do that. But that typically requires extra lens and the slit lamp, extra lenses in the slit lamp itself to really get a good view. So we'll start the exam, of course, with vision check. And so I really highly recommend having a vision card, such as a Snell or a Near card. It doesn't really matter if you're checking the vision at distance or up close, as long as you have some way to measure the vision. There are apps on the phone that you can have available to you, or you can have a physical card that you can have available to you to check vision. So typically, a lot of people aren't very clear on what a 20/20 vision or what a 6 out of 6 vision actually means. So a 20/20 vision means that the patient is able to see at 20 feet what a normal patient is able to see at 20 feet. So they have normal vision. A patient who sees 2200 means that they're able to see at 20 feet what a normal patient is able to see at 200 feet. So if you understand it that way, it's helpful. Moving on from the vision, after you've completed your vision check, your next move would be to check the pupils. The vision exam combined with the pupil exam really does evaluate the visual pathway from the eye to the brain. So here, you're really looking at the extent and the symmetry of pupillary response and looking for a relative afferent pupillary defect, which means that you're looking for any kind of discrepancy between the pupils as to how well they're responding to light, how quickly, how briskly, and to what extent. This is a challenging exam, and I would say that even in a normal setting with the perfect kind of lighting, it can be a difficult exam to do at times when the finding is very subtle. But what can really help is involving the patient in the exam. So, for instance, if you suspect a relative afferent pupillary defect, which would point to one optic nerve not working as well as the other, you could ask the patient to look at a red object and see if it looks just as bright in one eye versus the other eye, which would confirm your suspicion that one eye may have an optic nerve issue versus the other eye. And then also just with the intensity of light, if you have your pen light and you're shining in one eye versus the other, if the patient is saying that it's brighter in one eye versus the other, it can really help you to figure out to see if you're suspicious for an optic nerve issue. It is always mandatory to check pupils in a patient that has any kind of eye movement abnormality. What I mean by that is any suspicion for a cranial nerve palsy, orthosis, or a droopy eyelid. We should always, this is a very favorite test question, of course, from our testing during medical school, but we should always remember this entity of a third nerve palsy, which if it's pupil involving, as we see in this patient, you see this patient has a slightly more dilated pupil on this left side versus the right side, and they're clearly having a droopy eyelid on that side. That's the examiner is having to lift up the eyelid, as well as that misalignment of the eye with that eye down and out. Of course, you're really suspicious for a third nerve palsy that's pupil involving, which requires urgent neuroimaging. So we should always really, I think the takeaway from this slide is the pupil exam is very, very critical in a patient complaining of double vision or ptosis, because that really helps you identify any possible palsy, such as a third nerve palsy. And then moving on to the eye pressure assessment. So a tonal pen, such as what I'm showing here, is really helpful as a good screening tool for eye pressure measurement. And normal eye pressure ranges between 10 to 21. However, digital palpation, just feeling the eye relative to your own eye or to the patient's other eye, is also a really helpful way to see if the patient's pressure is highly elevated. So if a patient is coming in the emergency room or in the acute setting in angle closure attack, their eye is going to be rock hard, and you can just palpate the eye and compare it to the other eye to really get at that information, which is all you need to know, is this pressure extremely high or not. So you don't necessarily need to get a particular number. So don't, forget to do that digital palpation and actually get a sense for the intraocular pressure. And then visual field testing by confrontation is a very gross exam that looks at the field of vision. So far, with the visual acuity testing, you're really testing the central visual acuity. You're not testing the field of vision. And a patient complaining of vision loss isn't going to tell you it's my central vision versus my field of vision. So it's up to you as you're evaluating the patient to discern whether they're complaining of a central vision loss versus a field cut. And the confrontational visual field testing is very, very helpful in delineating those two. So in the acute setting, also, you're really thinking, is this patient having a neurologic vision loss versus an ophthalmic vision loss? So it also helps you in delineating this. A field cut that respects the vertical meridian, or that respects the vertical midline and is symmetric, is highly suggestive of a neurologic or brain closer to the brain kind of problem, versus a patient with vision field cut that's respecting the horizontal meridian. You're thinking more, okay, an extensive ocular issue such as a retinal detachment, say, or an optic nerve on one side. So the field of the visual field testing, while very gross, can really point to first, whether it's a field issue versus a central vision loss, and secondly, whether it suggests more of a neurologic cause or ophthalmic cause. And then, of course, motility testing interrogates the rest of your cranial nerves 3, 4, and 6. And I would say that any patient who's coming in for diplopia or a double vision complaint, an acute double vision complaint, should have a few things clarified. So we should know whether the patient is complaining of a monocular double vision versus a binocular double vision. A monocular double vision means that the patient still perceives doubling of their vision even when they occlude one eye. So that tells you already that this is an ocular problem and can be evaluated in a routine fashion. There's no emergency there. But a binocular sudden double vision, it requires more urgent evaluation. It helps to know whether the doubling is horizontal, vertical, or oblique, to sort of think about what muscles may be involved. And then it really helps to know if it's intermittent or constant, because an intermittent diplopia you're less concerned about and can kind of have that evaluated outpatient on a routine setting by an ophthalmologist, versus a constant sudden doubling of the vision makes you think about an acute vascular or vascular issue potentially, and things like third nerve palsies that you have to address very quickly. Moving on, we're going to talk about now to the assessment of the trauma patient and sort of important considerations in that. So of course, a trauma patient is going to present with pain. They could present with vision loss or double vision. And so the assessment as the first provider seeing this patient it has to do with first understanding the mechanism of the injury, assessing the vision, pupil, eye movement, and a thorough pen light exam very quickly. And what you're really trying to do is address a few things. So first is to rule out a ruptured globe or retroorbital hemorrhage, and in the pediatric patient, something like a trapdoor fracture. So these have to happen very quickly in order to really triage the patient appropriately. Of course, later, after these things have been ruled out, these patients would benefit from imaging of the orbit to really rule out orbital fracture. And every patient with a traumatic orbital issue should really be instructed and to not blow their nose, things like that, in the time in the time from that incident to when they will be evaluated by an ophthalmologist. So as long as this assessment of a trauma patient is done, I think a good amount of work has been done prior to further evaluation by an ophthalmologist. So a trauma patient can be very difficult to examine from just the access and because there's swelling, hematoma around the eyelid. So exposure can be very important. And I have these images here showing a Damar retractor opening up the eyelids, but we can also use something as simple as a paper clip to make a Damar retractor out of that by just bending a paper clip and using that to really give you a really good exposure of the eyeball. With that, I'm going to go through, some of those things that you're trying to rule out. So starting with a ruptured globe. So a ruptured globe, of course, is a full thickness scleral or corneal laceration that can be evident, such as these. This patient here on the right is clearly showing iris coming out of the eye, a really shallow anterior chamber. So, you don't have much question here as to what's going on. But sometimes it could be that the patient presents with severe subconjunctival hemorrhage, 360, with a history that's suspicious for a penetrating injury. And they could have, like I said, shallow anterior chamber, a low eye pressure. So you feel the eye and you can tell that compared to the other eye, the pressure feels quite low. The pupil doesn't look round. It doesn't matter. It could be in the sclera that the uvea is prolapsing out of the eye. So if you're seeing a peaked pupil or some fluffy material in the anterior chamber from a disruption of the lens, all these things should make you very, very suspicious for a ruptured globe. And then hyphema as well. With the right history and a significant blunt or sharp trauma, hyphema or blood in the anterior chamber would make you very, very suspicious for a ruptured globe. For these patients, as the primary provider for this patient, or if this is a family member or this is happening in the field, the most important thing is to shield the eye. Sometimes we see patients patched with a gauze or something like that, which is always a little bit scary, because if you have uvea or tissue like iris contacting a gauze directly on the eye, with removal of that gauze, you could be pulling uvea or tissues out of the, out. So that's not what you want. So you want something that shields the eye and kind of protects from further expulsion of the eye contents. So these patients also require a CT scan of brain and orbits to make sure that they don't have a foreign body in the eye, because you obviously, if we don't have the scan, that can be missed. And these patients have to be NPO and put on bed rest until they are evaluated fully by an ophthalmologist, ideally in the operating room, where their injury can be addressed. These patients need to have IV antibiotics given to them as a prophylactic measure. A tetanus prophylaxis has to be given, and pain and nausea control, so that they can be comfortable and not increase pressure around their face from vomiting or something like that, that could further expose more of or cause more injury to their already ruptured globe. Here is a nice image just showing that sometimes, these kinds of ruptured globe cases can be very, very subtle. This patient, if you saw them without a fluorescein applied to the ocular surface and a blue cobalt light shown onto the surface, showing this kind of, this, if you're looking at it dynamically, you'd be seeing a flow of fluid from the eye, telling you that there's aqueous that's slowly leaking out of this eye, and this is a ruptured globe as well. So a ruptured globe can have very varied presentation, and so you really have to be an astute observer of some of these really subtle findings. And then the second entity in the trauma setting that I want to go over is the traumatic retrobulbar hemorrhage. I started on that earlier on the slide, looking at the anatomy of the orbit. These patients also are presenting in a very similar way with a pain, loss of vision, and severe eyelid swelling. Here, the key is that really severe, rock hard eyeball and eyelid, that you're having even a lot of difficulty opening up that eyelid. Just that part of the exam should really make you concerned for orbital compartment syndrome. The eye will feel really rock hard, even palpating it just directly over the lid. And you're really, at this point, really concerned about ischemia to the optic nerve and the retina. So these eyes, this is an intimidating patient to see, obviously, because you do have to act very fast. And one of the things that would really help is, doing that pupil exam and seeing that there is a relative afferent pupillary defect, and that eye on that side is just not responding in terms of the pupillary response compared to the other eye. And this requires an effective and very quick decompression of the orbit. So what then you would have to do is basically, here's the, like we mentioned earlier, the lateral orbital rim. A blunt pair of blunt scissors should then go right in that soft tissue anterior to the lateral orbital rim, and you just make a cut. There's really no significantly, significant anatomy other than the globe. You don't want to hit the globe, obviously, and you have a blunt needle, a blunt scissor, but numbing the patient and really making that lateral cut is really going to decompress that orbit. If that's not sufficient, sometimes cutting the lower lid just straight down could also be very, very effective. So as intimidating as this may be to do for the first time, it's something that, that can really save someone's vision, someone's eye. So an important thing to just be aware of. Moving on to less intimidating issues that can happen in the trauma setting. Here we're seeing hyphema, with blood that is layered in the anterior chamber. And these patients can present from mild blunt trauma or other reasons that there are other reasons why they could have a hyphema. However, in the trauma patient, it would be fairly apparent. The concern here is not, once you've ruled out things like ruptured globe, is the eye pressure, because as much as there might be blood that could fill the eye sometimes and really raise the eye pressure, even in cases where the blood is not filling the whole anterior chamber, you could have cells floating in there, clogging up the anterior, the trabecular meshwork and elevating the eye pressure. So these patients have to be monitored for elevated eye pressure and treated with topical eye drops, and potentially Diamox and things like that to lower the eye pressure. Anytime you see a patient with a history of trauma and a hyphema, requires, again, an evaluation, an imaging evaluation to rule out intraocular foreign body. But the history is really helpful to guide you whether or not there's some suspicion for an orbital or intraocular foreign body. Sickle cell patients tend to do worse, so important to know if there's that history, and typically just let the patient know to rest so that the the blood can really layer and allow them to actually see a bed rest, head of bed elevation, and a quick evaluation by an ophthalmologist as quick as possible is what would be recommended here. Metallic foreign body, a very, very metallic or other foreign body, really a very, very common issue, especially in the settings where people don't tend to, use eye protection routinely while they're doing work that can result in a flying foreign body. There's a few things to realize here. It's important not to do anything in terms of trying to remove foreign body from the cornea, especially unless you're able to have this view of the cornea and you're sure that this is not a penetrating foreign body and that it's embedded in the cornea, but not full thickness. So unless you have a slit lamp that you're looking, to make that judgment, I wouldn't do anything in terms of trying to remove a foreign body that you can't fully evaluate through a slit view like this. But if you do have that view, then we typically take a 25 or 30 gauge needle and bent and kind of flick this out and put the patient on a broad spectrum and topical antibiotic. Regardless, whether or not you take out the foreign body, you would put the patient on broad spectrum topical antibiotics, typically every 2 hours or from every 2 hours to four times a day until they're able to be evaluated by an ophthalmologist to prevent possible infection. And it's always very, very important to flip the lid. Patients are allowed to have more than one foreign body at a time. So if a patient has this that you can see, you have to flip the lid and really make sure that they don't have any other retained foreign body in the eye. Corneal abrasions. Corneal abrasions can be a cause of severe pain. A patient will tell you that they maybe, did something, their kid scratched their eye or something got in their eye, and it's very painful as the cornea is the most innervated part of our body. There's tearing, there's photophobia, and when you just look at the eye may be red and irritated, but you may not see anything on the cornea, which is why it's very important to use a dye, such as a fluorescein dye, strips shown here, but it can come in a bottle as well, that you then place in the eye and shine a blue light, whether or not you have really the blue light or the slit lamp. I'm showing here an image in the bottom that shows the fluorescein uptake with a pen light exam. So you would see that as long as you have fluorescein available, you'd be able to see that green area telling you that this patient's pain is from a corneal abrasion. So it's mandatory to apply fluorescein dye to really, really be able to see these. And if you see that green uptake, but you do not see any opacity in the cornea, you're reassured that hopefully there's not an actual ulcer or an infection going or brewing, and that you can put the patient on prophylactic antibiotic. Depending on your suspicion and the mechanism of the trauma, you can put them on every 2 hour or 4 times a day of antibiotic and get them followed up with an ophthalmologist within a day or 2. So these patients are very, very uncomfortable. There's a lot of pain. So typically we don't advocate for patching the eye or, but just, kind of instructing the patient to close their eyes, be in a dark room, if, just for the photophobia. And typically these abrasions heal very, very fast. Sometimes even in surgery, we have to, abrade the cornea, and by the time you see them in post-op day 1, the very next day, sometimes they're completely healed. So it's very, very remarkable for a healthy patient how quickly they can heal their epithelium, as painful as it is to start with. Along the same lines, chemical burns. This is a devastating injury when it does happen, especially with the alkali chemicals. And so the key here is to irrigate with whatever is available quickly. So if there's saline or LR available, just really irrigating as quickly as possible, even if it's tap water, if this is something that's happening out, to someone that, out there in the real world, you just would irrigate until the pH normalizes. Typically, you check the pH. If you're in the emergency room or something like that, keep checking the pH. Keep irrigating until you get a neutral pH reading. And then if you see a particulate matter, it's really important to evert the eyelid, to flip the eyelid and look for any particulate matter, such as, if it's a cement injury or something like that, that would continue to have that corrosive or abrasive potential. So it's really important to sweep the fornices of the eye and make sure that any particulate material is addressed. And then, of course, these patients have this huge epithelial defect, typically, that you would then, put them on antibiotics and have them follow up with an ophthalmologist very, very quickly. Whenever you see this kind of ischemia or whitening, it's an ominous sign that the injury is extensive and there's a limbal stem cell loss. So these patients tend to do very, very poorly, as you can see here, with just conjunctivalization of the corneal surface and really, really terrible scars. So moving on to iritis, this is a situation in which you're seeing a patient, again, of course, with pain and red eye and photophobia, but you don't have a corneal abrasion. You don't see any lesions on the cornea or any kind of other focal lesions. And so you're really thinking, okay, so it's not an abrasion, it's not an ulcer, it must be inside the eye. So if you have a slit lamp available, or in certain cases, you could even see a layer of white cells in the anterior chamber. Of course, that will tell you that there's inflammation inside the eye. But this diagnosis typically really does require a slit lamp to make. So in these patients, one telltale sign that's helpful, if it's there, is that this kind of a redness that's circumlimbal, right around the limbus, versus diffusely around the eye. You can tell that this eye is red right around that junction between the cornea or in the sclera, which is called the limbus, versus elsewhere. So that can really kind of clue you into more of an iritis cause for the redness. But this is a really difficult diagnosis to make without a slit lamp. So if you have a slit lamp available, though, you'll be seeing anterior chamber cells that would then require a steroid treatment. I am somebody who really advocates for not treating with any kind of steroid when you see a patient for a corneal, or when you're even suspicious for iritis, because of the particular issues that steroids can have if not followed up very, very closely. So antibiotics, anytime you're thinking abrasion, ulcer, very important to cover with as broad an antibiotic as you can get, versus steroids have to be really used very, very cautiously. Okay, speaking of, we'll talk now about infections and inflammations, starting with ophthalmia neonatorum. I bring this up because it's a very, very important entity and something we should always keep in mind. So diffuse conjunctival injection and purulent or mucoid discharge in the first month of life is an emergency. Essentially, these patients, have this kind of, discharge. If there's a lot of discharge, you're very, very concerned. Even if there's a little bit of discharge and the conjunctiva is highly injected, these patients need to be evaluated very quickly. Of course, typically what we do is get a scrape for a Gram stain or a Gimses stain to really tell us the possible etiologies, which the top etiologies that you're really concerned about are Neisseria, gonorrhea, chlamydia, and it could be run-of-the-mill, staph, strep, it could even be herpes. But the most important thing is to really be, suspicious and quickly act quickly to get these microbiologic workup if you're able to, and if you're not able to quickly start these patients on systemic and topical erythromycin. You see there that for the elixir or the oral, typically we start these patients on 15 milligrams per kg per day Q for about 3 weeks. If you have great suspicion for Neisseria gonorrhea based on the history that the mom is providing you, or they have just highly purulent discharge that you wipe and then it reforms right away, that's really, really concerning for gonorrhea, which should be treated with ceftriaxone injection or IM. So this entity can be confused, or sometimes can be confusing to primary care providers with something like a nasolacrimal duct obstruction, which would cause more of a tearing and not have as much of the diffuse conjunctival injection part of it. So patients who pediatric patients like this, their tear the lacrimal system may not be fully functional at this point, can have tearing, a little bit of discharge in the morning, but significant discharge, significant injection of the conjunctiva is very, very concerning. And typically these patients are admitted and followed very closely. Moving on to other infectious entities, corneal ulcers, of course. So infectious keratitis is a really, really important cause of unilateral vision loss in the world and of corneal blindness. And these patients, of course, present, as in the other patients we're talking about, with painful red eyes. And the acuity really here matters. So a patient who tells you that they have an eye that appears like this when you see them, you're really, really worried for an aggressive bacterial process. And really has to be addressed very quickly with as broad spectrum antibiotic. Typically, what's advocated for is broad spectrum antibiotic in the form of fluoroquinolone and aminoglycosides. And then, of course, based on the history, there are other things that could be going on here: viral infection, fungal, parasitic infection. And I'm showing here, if you're lucky enough to get the appearance of a dendrite as seen in the image on the right, that is telltale of a herpetic process. But typically that could be sorted out with the ophthalmologist. The task here is whenever there is an opacity with a lot of discharge on the cornea, then that should be really quickly treated by a broad spectrum antibiotic. All right, excuse me, I'm going to change here. So moving on to some specifics that can be really helpful in treating ulcers. I'm just kind of highlighting here a dendritic ulcer of the cornea, something that can be very, very interesting to diagnose, and something that that if you see, you can really make the diagnosis without microbiologic workup even. So a red eye patient presenting with a little bit of maybe an eyelid rash, or may not even have a rash if they've been previously exposed to HSV, which, most adults have been to HSV1. This kind of appearance that we call a dendrite, which is an epithelial lesion on the cornea that under a cobalt blue light after application of fluorescein would just look like this dendritic lesion, would just tell you that this patient has a herpetic keratitis. And these patients are treated with acyclovir. We typically prefer oral for 400 milligrams 5 times a day versus, and these tend to happen more in younger patients versus the patient that you see here on the left, who's clearly has this V1 distribution rash, shingles basically, and with involvement of the eye. There's something called the Hutchinson sign. If you see a lesion on the nose, because of the distribution of the nerve supply to the eye and that the tip of the nose, you're really, really concerned for the herpetic process involving the eye as well. So typically these patients are treated with acyclovir 800 milligrams 5 times a day, and then you get them in to see the ophthalmologist. So HSV and VZV can have a very complicated course with immunologic reaction to the initial infection that can require steroids and a very prolonged course. But I think for the primary provider, really, if you're able to examine the patient and see this dendritic lesion, or this patient clearly has that V1 distribution rash, then really moving ahead and treating these patients can be vision saving. If a corneal ulcer goes untreated, it can progress to endophthalmitis, infection moving to the anterior chamber and seeding the vitreous space as well. So that would be exogenous endophthalmitis. There can also be a post-op endophthalmitis of a patient who recently had eye surgery and presenting with pain and decreased vision. And as you can see here in this image, a hypopia and a white blood cell layered in the anterior chamber. This would be basically in the setting of recent surgery or trauma, very, very concerning for endophthalmitis. There are also really sick patients, perhaps in the ICU, who could be septic, that could see their eye and get endogenous endophthalmitis, but that's not as common. And just like the patients we've been talking about, again, decreased vision and pain, they could have lid edema, corneal edema, hypopyon, like what you're seeing there. This is really treated with injections into the eye. So the primary provider can really help by potentially putting these patients on systemic fluoroquinolones, which have some penetration to the vitreous, but really this requires an urgent evaluation by an ophthalmologist for possible or for injection into the eye with antibiotics. Okay, of the infectious entities, the last one we're going to look at is orbital cellulitis. And this is cellulitis, like any cellulitis that you have in other parts of the body, but specifically around the eye. So lid edema, redness around the eyes. And these patients could have a history of sinus disease or something like that. And the telltale sign for orbital cellulitis, which is an emergency because of that threat of vision loss, is that they have a vision complaint. So they would have pain with eye movement or double vision or a decrease in vision. Any cellulitis around the eye with any vision complaint or a subtle early sign could be a motility induced pain. So they're looking to the left and right and they have pain. That should really clue you into an orbital cellulitis process. Of course, if the disease is more advanced, or you catch it at a more advanced stage, the patient could be proptotic. As you can see in this patient, you can see that she has hypoglobus, or lower, the eyeball looks lower on that side. And typically these patients have sinus disease that has kind of spread contiguously to the orbit, or they've had recent orbital surgery or trauma. But this requires urgent IV antibiotic to get it addressed. I want to also mention that if a patient has any kind of immunocompromise, such as a diabetic in DKA, or if the patient has some other cause of immunocompromise, you really have to be suspicious for a fungal process, and really and keep that entity of a fungal sino-orbital disease in your differential diagnosis. So here, what I want to highlight is any kind of cellulitis that you see that has any vision impact or motility impact of the eye means that it has crossed the septum. It's no longer preseptal and it's moved to the orbit. And that really requires an urgent admission for IV antibiotics to decrease the sequelae to the eye. So moving on to ocular anatomic and vascular emergencies. We'll start with an acute angle closure glaucoma. This is typically going to be a patient who presents to you with severe pain, a frontal headache, blurred vision, halo around lights. They'd be kind of holding that side of their head, nausea, vomiting. It's not subtle. And typically, these episodes can be induced in the right patient or in the predisposed patient by dim lighting or dilating drops that they were given at their checkup recently, or that they've started a new medication that has some anticholinergic activity. And the eye on that side would be rock hard to the touch. Their pupil would be minimally responsive to light. And their corneas, as you can see in this patient, could be quite hazy or just not clear. So that combination of painful eye with a rock hard, feel to it and a hazy cornea should really clue you into that acute angle closure diagnosis. These patients are treated with whatever you can get your hands on for IOP lowering every 15 minutes. So there are several different classes of IOP lowering medication. Whatever you have access to at the time should be given every 15 minutes. And hopefully you have access to Diamox, acetazolamide, either PO or IV. It should be given right away. The only thing is to make sure the patient is not allergic to the sulfa class of medication. And that would be how you would start lowering the eye pressure to address this medically. And this would be, if we leave this patient untreated to be seen by the ophthalmologist, by the time they're seen a day or two later, they will have lost vision permanently. So the primary care provider, whoever's seeing this patient, can really, really save vision by starting them and breaking this attack medically. Typically, even if you're being evaluated by an ophthalmologist, this is broken initially medically and then addressed definitively by a laser treatment in clinic. So this is an obviously very, very important entity to be very comfortable with. And then moving now from angle closure, I want to talk about now to entities that have a normal anterior segment appearance, but the patient is complaining of vision loss. So far, we really have to rely on our pen light or slit light exam to make the diagnosis. Moving forward, we really have to expand our differential diagnosis and think about things that cause vision loss without pain. So starting with the most serious of these is the central or branch retinal artery occlusion. This is essentially a stroke of the eye, and patients present with sudden painless vision loss or an altitudinal visual field loss. So they could say, I was just, doing what I was doing, and all of a sudden, I can't see this, top half of my vision, or something like that that happens very suddenly within seconds is what we're talking about here. And they might have had other transient vision loss episodes. That's what we call an amaurosis fugax. And they typically have a very dense efferent pupillary defect on that side. And the causes are typically, what you would think for a stroke, embolic, thrombotic, hypercoagulable state, or trauma-induced. An important entity here is giant cell arteritis that you have to consider. And really, if this patient is over the age of 55 and they're complaining of an acute significant painless vision loss, there should be an ESR and CRP ordered right away to be able to detect this entity. So this is a normal fundus that's shown here on the left. Looks, just a normal appearance with that kind of reddish glow to the retina. The retina is actually transparent. What you're seeing is the choroid or the blood supply in the back that gives the retina that appearance. Here you're seeing the clear whitening ischemic appearing retina from a central branch retinal artery occlusion. And then here in the image on the very right, you're seeing a superior branch retinal artery occlusion and that whitening of the retina. So this may actually be only viewed in this way in the acute setting, and the color can actually normalize after the damage has been done. But that history should be very suspicious for that. And if you're out in a normal clinic or in the emergency room, you can do what you can with a direct ophthalmoscope, but just be aware of this entity. But a dilated eye exam would be really, really helpful to make this diagnosis, obviously. Just to talk a little bit more about giant cell arteritis, because it is an important cause of sudden vision loss. It's very serious because it can go from unilateral to bilateral and cause permanent vision loss. It's only really suspected in patients over the age of 55. This is not an entity that is really seen in younger patients. So the things that really help with finding out if this is a potential entity you need to consider in your differential is by asking questions regarding headache, jaw claudication, scalp tenderness, proximal muscle or joint aches, anorexia, weight loss. So we're asking questions regarding polymyalgia rheumatica, which has an association with this condition. But this is basically a medium to large vessel vasculitis that has this really important ophthalmic complication associated with it. The definitive diagnosis is made by a temporal artery biopsy, and these patients typically are treated with long-term steroids. So to commit patients to long-term steroids, typically we have to get a tissue diagnosis. I'll move on to other vascular causes. This is, the blood and thunder fundus. Even if you look with the direct ophthalmoscope, you see all this blood splattered throughout the retina, and this is branch retinal vein occlusion. Vein occlusion, there's a lot to see, whereas branch retinal artery occlusion, there may not be much to see. So in these patients, they may present less acutely or in a subacute fashion. They may have a gradual decline in the vision over a week or two, because the vision loss in these patients is related to swelling in the retina as opposed to ischemic retina. So again, this is really the predisposing factors here is hypertensive or cardiovascular risk factors, and these patients can be seen in the ophthalmology clinic, within a week or two, and are treated with injections or laser. So just a dramatic kind of exam, but not something you really need to act on unnecessarily. Vitreous hemorrhage, of course, here, this can be a very common cause of vision loss, especially in the diabetic patient. And these are mostly related to diabetes. Patients will complain of just having suddenly black dots in their vision or webs in their vision. So the way they would describe their vision loss is very characteristic, because this is like blood, kind of filling the vitreous gradually. So they would say, I started to see just webs or black spots that came in my vision. And where you're trying to look into the retina, this is what you see. You're seeing kind of, you can't see well. It's very hazy. And that should be with the right history of a diabetic patient, a long-term diabetic patient, then that really makes you suspicious for a vitreous hemorrhage, which can be evaluated in the ophthalmology clinic, pretty much on a routine basis. You can tell the patient to be, seated up to allow for the blood to settle. And there are other things like retinal breaks or retinal detachments that we are concerned about in these patients, and do an ultrasound to try to rule out in the acute setting. But that can be difficult to do at times. And finally, of course, retinal detachment, which has a characteristic history to it of flashes of light, floaters, curtain or shadow moving over the vision, typically in patients that notice this acutely. Really the role here is especially if their central vision is preserved and they're really talking about a visual field cut, these patients can really benefit from a very expedient evaluation there are, there are retinal surgeons available who have the ability to do vitrectomy and sclerobuckle, which are the procedures to reattach the retina. So if this entity is caught very early, especially if it hasn't involved the macula, the urgency increases so that you can get to the patient, hopefully the OR before the macula is involved. But that can be very, very difficult at times given resource limitations. And so I think these are the most important entities I wanted to cover. I want to conclude by saying that the vision and pupillary exam really interrogates the whole visual system. And so it can be a really helpful tool in evaluating patients with acute vision loss. You can save vision by having a clear approach to your ocular and trauma patient. So kind of a mental rehearsal of, if I had to do something in this situation, what would I do and what would I look for? Acute angle closure attack, if diagnosed, can be addressed by the primary care provider and await for a definitive treatment at a later time. So that's really one way that providers can really save vision, by breaking an acute angle closure attack at the setting that they're evaluating the patient. And a patient with a normal appearing eye but a significant vision loss needs an urgent evaluation with a dilated eye exam, because at that point it can be very, very difficult to make the diagnosis unless you're able to dilate and evaluate the patient fully. And with that, I will hopefully transition to the next portion of our session with the questions, and then we can have a Q&A hopefully very soon.
Thank you, Dr. Bethelehem, for this very nice and engaging presentation. We have around 11 questions raised by our participants, and I'm going to share the questions with you. The first question was to consider a reduced vision as surgery related. Within how much time should the patient present to us?
So to consider a reduced vision as surgery related, so I would say that a patient presenting with having had surgery in the past, within the past month or so, would be concerning for any kind of vision loss within a month of having had eye surgery. You can really be concerned that may be related to the surgery they just had.
All right. The second question is, which imaging is better for assessment of eye trauma and or metallic foreign body, and any contraindication for imaging in case of metallic foreign body?
Yes, that's a really, really good point. Patients should be initially assessed only with a CT scan. MRI would not be the first. It's also more expensive, and so thankfully a CT scan is really helpful. Even we typically don't utilize X-ray, but it's and wouldn't be a good evaluation for metallic foreign body or for looking at something in the orbit in the eye. But a CT scan is the go-to, and imaging patients with who've just had trauma or ocular trauma or possible metallic foreign body with an MRI obviously would be contraindicated.
All right, then we proceed to the third question. The third question was, will saline irrigation harm or help in case of eye trauma with or without ruptured eyeball?
Yes, so you wouldn't want to do any kind of irrigation of a patient with a concern for ruptured globe. So if you for the reasons that we discussed, if you suspect a ruptured globe, really all you'd have to do really for that patient, other than some of the IV antibiotic prophylaxis, tetanus shot, and making sure their pain and nausea is controlled, is really making sure that eye is protected with a shield. So no irrigation, no further manipulation of those eyes.
All right. The fourth question was on the management of specifically corneal edema patients with with no epithelial defect?
That's a great question. So in a patient with a corneal edema, you have to make sure that you're not dealing with, and again, acute ankle closure by making sure the pressure is normal or, symmetric between the two eyes. A corneal edema patient without an acute, ulcer or a clear ulcer or an epithelial defect can really be evaluated by an ophthalmologist in the next, week or two. There's not really anything I would be urgently, or emergently kind of considering. So as long as you really are able to assess the epithelium and you're able to rule out an infection, which is my number one concern. Even in those patients, it would not hurt to put them on some antibiotic if you're really not sure of infection or not. But really, infection would be the number one concern, and if that's not the case, then the differential diagnosis is really less acute.
And the fifth question was, what is the reason that we use acecloprid 400 milligram for herpes zoster and acecloprid 800 milligram for varicella zoster?
This is a great question, and I don't know. I have to really think about that. It's just sort of the recommended treatment, higher doses for zoster versus for HSV1. I think that's a great question. Other than what's that is the recommended dose for treatment. So that difference is very important for shingles versus HSV. Even in the prophylactic, for patients who we get recurrent HSV, we prophylax with 400 versus 800. So that is the recommended dosing. As to why precisely, I have to get back to you on that. I can't say for sure.
Okay, thank you, Doc. And the next question is about the ophthalmic case and site to describe in the investigation of ophthalmic. Is it the sclera cornea or the conjunctiva or the
Great. That's a great question. So you have to first clean the excess mucus and sort of the clearly visible purulent material, because that's just necrotic tissue and immune cells that are not as helpful. So once you've really rinsed out the eye or cleaned the visibly purulent material, you want to put your Q-tip or whatever you're using to scrape into the fornix, kind of put it right into the conjunctiva and really scrape the conjunctiva. So as deep as you are able to get your Q-tip. So the main thing is cleaning the excess discharge and then really getting to the conjunctiva and scraping there. And then if we're talking about a corneal ulcer, you want to, again, you're typically, not really culturing these patients without the use of a slit lamp. We have to really use a slit lamp to culture corneal lesions. And typically we try to scrape at the base and not at the center, at the ulcerated area, because then you might yield more of just necrotic tissue. So you want to always culture the leading edge of the infection.
Thank you. The next question is, what is the difference between retinal detachment and commotio retina?
So so that's a good question. Commotio is more of a differential in a patient who has some sort of trauma and a whitening of the retina, versus a patient with a retinal detachment, which could also be caused by trauma, has a retina that's kind of has fluid under it, and it has this kind of corrugated appearance, and it's kind of just this wavy appearance. So a detached retina versus a retina that's kind of in shock and potentially ischemic and white, which is how commotio would appear much. I think commotio would be more in the differential diagnosis for a branch retinal artery occlusion, that similar appearance of a stunned or a a white retina versus a detachment, which would have that, fluid under the retina, corrugated appearance that I showed in the images.
The next question is, how can we differentiate endophthalmitis from other less serious causes of red eye?
So a really good question. It can be very difficult. Again, that slit lamp dilated eye exam is very, very important. But typically, you have the history is very important. So a patient who is, let's say you're saying a young patient and they have a red eye, very painful. And they just had surgery, you're already very concerned for endophthalmitis. You're not thinking about other causes if they've had surgery. If they've had recent eye trauma or something like that, you're thinking, a serious infection. Or if they've had if they clearly have a corneal ulcer, that is one reason to have endophthalmitis. The eye, otherwise in a healthy patient, endophthalmitis, you should have an explanation for why they have that, because it's infection inside the eye. The eye is immune privileged. So unless they are very sick in the SICU and they have endogenous endophthalmitis, or they're severely immunocompromised and they have endophthalmitis for that reason, a patient with a red eye and otherwise, it's not, the diagnosis of endophthalmitis is only entering your mind for the things we talked about: a post-op patient, a corneal ulcer patient, a very sick patient in the ICU or something like that, or a very immunocompromised patient. And in those patients, you could be seeing a layered white cell in the anterior chamber, a hypopyon, that would really make you suspicious for endophthalmitis.
Thank you, Doc. And the next question was, can flu medications like chlorampheniramine and pseudoephedrine precipitate acute angle closure glaucoma? And with it, can you answer also, could you please elaborate on the management of acute angle closure glaucoma in primary care settings in a country like ours?
Sure. So I would say that, yes. So any medication with anticholinergic, it's in the label, it's in the warning, can precipitate any medication, such as those that you mentioned for flu or for a cold, can precipitate an angle closure attack. So important to get that history. Although, a remote possibility, but definitely a possibility. That's one. And in terms of the management of acute angle closure, so I would say, it's whatever you can get your hands on. So there are, sometimes we could have an eye pressure lowering drops, drops available to us. Sometimes we may not. So if for instance, if you don't have any drops available to you, Diamox is really, really helpful. IV Diamox is better, but even oral Diamox, several doses given can really break an attack. And then also considering mannitol. Mannitol is very much available. So IV mannitol, while you have to do this in a very controlled setting, would require IV access. But IV mannitol is sort of the ultimate treatment that will break that block. So, and IV mannitol is fairly available. So, but in the primary care setting, it can be difficult to address this issue if you don't have, eye drops that are just there and accessible to you. So you have to use whatever is available. And I would say, typically acetazolamide is fairly available and cheap, cheaper medication. And also mannitol is, but mannitol, you just have to be comfortable with some of the, issues with that. For instance, it can be, you have to make sure that your access is very, very good when you're having, when you're giving that through an IV. But it can do the trick.
Thank you, Doc. And the next question was, how can one be sure about posterior blunt globe injury and manage the management approach of posterior blunt globe injuries?
Ruptured globe? I'm sorry, I missed the first part. Can you repeat that question one more time?
How can we be sure about posterior, on the diagnosis of posterior blood globe injuries and management approaches.
Yes.
Condition.
So again, 300, the history, very important. What happened to that patient, very important to help you assess the level of the trauma. The significant, the severity of the vision loss, right? You have a trauma patient who had this severe sounding injury and their vision is down from normal quite a bit. And there is maybe a remarkable subconjunctival hemorrhage that's 360 degrees around the eye. Things that we mentioned, a lower eye pressure on that side, because a ruptured globe means that the eye is leaking from somewhere, right? Whether it's posteriorly or anteriorly, the integrity of the eye has been compromised. So that eye will feel softer. Some of the anatomy when you're looking at that eye may be distorted. So, or if it's posterior, it could be more of a lens problem where, you may see the lens jiggling, or there's maybe some lens material in the anterior chamber. It can be difficult, but when in doubt, you can assume that they have a ruptured globe until they can be evaluated further and treat that patient as if they have a ruptured globe. So the extent of the trauma, the severity of the subconjunctival hemorrhage, the eye pressure, these are all kind of clues to help. But ultimately, if you're unsure, you just treat that patient as if they do have a ruptured globe, and so that they can be evaluated very, very quickly.
Okay, thank you. The next question is, are there any specially made strips to check the pH when following chemical injury patients and while irrigating?
Yeah, so, if you don't have an pH meter available, keep irrigating, for maybe, an extended period of time. It can be really difficult as if you don't have, a pH meter, which, for instance, I have a little call bag and I always have something like that available, but it's not, it's not always that you would have something like that, but and it depends on the, practice, where you're practicing. So irrigating for a very long time. I don't have a great way otherwise that you could check pH other than a pH meter.
The next question was, could you please elaborate on the difference in the patient presentations of ophthalmic emergency in the Western healthcare setting and those in Ethiopia?
Yeah, I think, trauma is trauma anywhere. I think that, so for instance, so trauma, across the board, it's, I don't think there's any major difference there, perhaps. But, in terms of, construction workers or, metal workers, things like that, using protective equipment is variable, of course, based on, if you're in a place where those things are very available to you versus not. So the risk of seeing these injuries is much, much higher in Ethiopia than it is in the Western world because of access to those kinds of supplies, obviously. And then other considerations are when you see a corneal infection in the Western world, you're thinking contact lens wear and, the kind of the etiologic factors are typically bacterial and viral, versus in the setting of Ethiopia, you may be thinking about more trauma and exposure to trauma, very important exposure, and some other fungal causes of infection that can be associated with traumatic causes of corneal ulcers, and things have to factor in more. So I think in the acute setting and in the ophthalmic emergencies that we're talking about right now, I think in your management of those patients, because of your the availability of ophthalmologists is not going to be obviously as much as what we have access to here. So the primary care doctor has a lot of responsibility in terms of stabilizing or putting those patients in a holding pattern much more. So some some level of comfort with these issues is very, very helpful. But I would say that, in terms of emergencies, I don't see a huge difference other than what I've mentioned.
Okay, thank you, Doc. The next question was, for herpetic epithelial keratitis, which one would you prefer, the PO cyclovir or the topical ones?
Yeah, so I think, I was trained at UCSF in the Proctor Institute that really did a lot of research in this topic. So I definitely favor oral treatment to topical treatment. And the reason is topical treatments sometimes can have their own abrasive qualities to them, especially medication that we in the US don't have access to acyclovir topical, but we have trifluridine, which can be pretty tough on the ocular surface from a toxicity standpoint. So the oral medication is just so well tolerated. Acyclovir is just an old medication, very well described, a side effect profile, very well tolerated by patients. So it's a really, really good medication. So the oral, if it's available, is a better choice, in my opinion.
Thank you, Doc. The next question was, for deep corneal foreign bodies, if it enters the anterior chamber while trying to remove it, what will be our next approach?
Then it would be treating that patient like a ruptured globe patient. As you know, again, I think that removal really does require at least a handheld slit lamp type situation. And I didn't have it here, but maybe I should have had an image of, there are handheld slit lamps that are relatively, relatively cheaper than the whole, slit lamp situation, which you really only have if you have an ophthalmologist that's practicing with you. So it might be, something to consider in terms of, if you're a provider interested in addressing some of these issues, such as, as common as a, foreign body on the cornea. But if something like that happens and it's a full thickness penetrating type of injury, then it would be treated like an open globe, and it would need to be urgently evaluated by an ophthalmologist in the operating room to remove it.
For the sake of time, we only have one or two questions, and the first, at what age does you recommend to start solar eyeglasses?
Solar eyeglasses. So, as early as possible, I guess I would say, because, there are some things like pterygia and other solar related changes that can happen to the conjunctiva that are very, very common in the setting of Ethiopia and any very equatorial type of settings. So, in terms of protecting, from UV as early as possible, even kids can wear UV protective glasses. So if, for any kind of extensive exposure to UV, protection is always recommended.
Okay, the last question, that is, the presence of floaters in the eye puts a higher risk for retinal detachment.
Yeah. So floaters are very, very common complaint, and they can be really scary to patients, but can be as benign as a posterior vitreous detachment, just something that happens very, very commonly in adults. And they would see sudden floaters in their vision, and it can be really scary. But, a large majority of those patients do not have a retinal tear or detachment. So what they require is to see an ophthalmologist within a week or two for a complete dilated eye exam to make sure there's no tear or detachment. So I would say that's a complaint that does require an ophthalmologist to really evaluate with a dilated eye exam to look at the periphery of the retina, because you're not only thinking about a retinal detachment, but you're thinking about the precursor, which is a retinal tear. But it's not an emergency necessarily, or it can be done within a week or two of that event. If it's associated with a constant flashing in one part of the vision, or spots in the vision all of the sudden, like multitude of spots associated with flashing lights, that kind of increases the likelihood of a retinal tear or detachment. And so that patient probably will need to see an ophthalmologist as soon as possible before this really comes to affect their vision. So it depends a little bit on the symptom onset, and also on what else is associated with it, whether vision loss or photopsia, flashes of light.
Thank you, Doc. I think we have answered more or less all the questions, and thank you for the great presentation.
Thank you so much, everybody, for your attention, for attending, and also for those questions. And I hope this was helpful somewhat.
Okay. Thank you very much, Dr. Lou. And thank you very much, Dr. Bethelehem. I think the questions that were raised were interesting and engaging, but unfortunately, time is a big constraint, and we couldn't address all of the questions that were raised. But nevertheless, thank you very much. Thank you to our participants that have been actively engaging in the Q&A session. So we'll just briefly go over the post-CME quiz questions. We'll attempt them together, and we'll wrap up the webinar. So the first question reads, which of the following is not recommended for a patient who presents with the finding below? There's an image that's already attached, as you've already seen for yourselves. So the first choice is eyelid closure and rest. The second is topical antibiotic eye drop. The third is topical steroid eye drop. And the fourth and the last is close follow-up. So Dr. Bethelehem, if you could go over it briefly, please.
Of course. Yes. So we're seeing a patient with a pen light exam showing a fluorescein uptake on the cornea concerning for a corneal abrasion. So in this patient, we will do all of the options other than starting this patient on topical steroid eye drops. Steroids actually decrease epithelial migration and can interfere with healing, and they can also predispose to infection. So anytime we have a corneal pathology, we have to be really careful about considering any kind of topical steroid treatment. So an antibiotic would be, prophylactic antibiotic would be appropriate. Eyelid closure and rest would be very appropriate, and a close follow-up for these patients to make sure they're healing and not developing an infection is very appropriate. Then we can move on to the next question.
Thank you. The second question reads, which of the following exam findings are strongly suggestive of a ruptured glove in the assessment of a patient who presents after a blunt force trauma? So the first choice is severe subconjunctival hemorrhage. The second is irregular pupil. The third is low intraocular pressure. The fourth is limitation in extraocular motility. And the fifth is all of the above.
Yeah, so as we've discussed, I think we've focused on this topic. All these findings can be very helpful in kind of cluing us to the extent of the trauma, and also, will raise our suspicion for ruptured globe. So all of the above is the choice there.
Thank you. We'll proceed with the third question. So it reads, which of the following is false about angle closure glaucoma? The first choice reads, typically present with pain, headache, nausea, and halo around lights. The second choice reads, triggers include dilatation, dim light settings, and anticholinergic medication. The third choice reads, medical management is typically able to break an acute attack. The fourth choice reads, surgical intervention is oftentimes the definitive treatment. And the fifth choice is none.
Yes, so all of these are true. So E, I didn't make these questions very difficult for you guys. E, none is the option, and yes, the presentation typically is as described here. The triggers are as we discussed. the medical management is what's required initially, actually, to definitive, unless you have a clear corneal view, the laser peripheral iridotomy can be difficult to do in the very, very acute setting. So lowering the pressure to some extent, making the cornea, return to to improved clarity can be very helpful in addressing surgically with the laser. So, the medical management is able to break this acute attack. So E, none is the answer there.
Thank you. So the fourth and last question reads, which of the following is not appropriate workup for the following condition? There's an image that has been attached. So the first choice reads carotid duplex Doppler ultrasound. The second choice reads cardiac evaluation with electrocardiography. The third choice reads ASR, CRP, and platelets. The fourth choice reads blood pressure check, and the fifth is none.
So E, none is the answer here. So basically, we're really considering a stroke workup for this patient. They've just thrown an embolic or thrombotic a plaque or clot that has caused ischemia to the retina, which is technically, sort of an extension of the brain. So this should be treated like a stroke workup, and including all of the above mentioned workup diagnostics. So E, none is the answer there as well.
So thank you very much. So we're done with the CME quiz. So that will be the end of our webinar. Thank you very much, Dr. Bethelehem. It was a very interesting and engaging webinar. And thank you to everyone that has attended. I hope the webinar was as engaging and as informative as it was for most of us. So with that, we'll be wrapping up our webinar. Thank you.
Thank you so much, everyone, for your kind attention.